Hello, everyone. This is Mickey Eisenberg, and welcome to another Vodcast from the Resuscitation Academy Network. I'm pleased to welcome two individuals from the other side of the world in Australia, Professor Karen Smith and Jocasta, both of whom work in the Victoria Ambulance Service for a region of about 6.5 million people. I'm going to turn to Karen first because she, along with Jocasta, worked on an article that was recently published, and we'll describe that article in just a second. But Karen, what were some of the reasons you undertook this study? What made you think there was need to even study what was going on? And it has to do with COVID-19, and the impact on cardiac arrest survival. So what prompted this study?
Yeah, thanks, Mickey. So I guess some of the context in Australia and Victoria, we obviously were experiencing the COVID pandemic, but not at the same infection rates that we were observing overseas. Our governments were very quick to instigate significant lockdown and restrictions. So I was observing what was going on overseas and could see some preliminary articles and newspaper articles coming out around the increased deaths and also the increased cardiac arrests consequently as a result of COVID. I was curious as to whether we were experiencing a similar thing in Victoria. Another reason too is that there were some clear reports coming out in our health system of reduced heart attack, STEMI presentations as a consequence of the lockdown. And probably because of the public's fear of going to a public hospital, and also the perception that our hospitals were completely overworked, which was actually incorrect. Our hospitals, the demand actually went down on our hospitals during lockdown. And so I thought that it's possible that if people were delaying seeking care for heart attacks, that may translate into an increased incidence in cardiac arrests. So we decided to use our established cardiac arrest registry to see whether incidents had gone up as a consequence of people delaying seeking care and what the patient outcomes were. And actually our findings were quite interesting and not really what we had expected given the relatively low incidence of COVID in our community. So I think Jocasta will take us through the study in more detail.
Well, good reasons to look deeper. So this study you did was published in Resuscitation, and there'll be a link to that on the network. But let me turn then to the first author of the study, Jocasta, and ask her to summarize what did you see and tell us some of the significant findings from the study.
Sure. So what we did was we decided to compare what was known as the first wave of COVID-19 in Victoria, and that was when we were put into stage 3 lockdown, which involved us all having to stay at home and only leaving our homes for certain things such as shopping and exercise. And so we looked at using the Victorian Ambulance Cardiac Arrest Registry. We looked at the time between the 16th of March and the 12th of May, which was that stage 3 lockdown. And we compared it to the prior 3 years of the same dates. And we combined that data for our comparator group. So we called it the pandemic period and the comparator period. And we found, like Karen said, some very interesting findings. First of all, we found that the rate of resuscitation was significantly decreased. So we saw a decrease from about 47% starting of resuscitation to a drop of about 40 to down to 40%, which was an interesting finding. And then when we looked at the people that did have resuscitation started, there was no differences with sort of age and gender and those sorts of things. But we found that there was less cardiac arrests in public places, for obvious reasons, given that we were told to stay at home. That also resulted in a decrease in the use of public access defibrillation in resuscitation attempts. And then we also looked at some time intervals as well. So, you know, the time to patient, time to at scene, time to at patient. And we identified a 2-minute delay in getting to the patient, which also resulted in that 2-minute delay in getting that early defibrillation to patients. We also found that bystander CPR had actually increased, but it wasn't bystander CPR in public places. We found the increase in private residence, which is also, you know, as a consequence of being at home with family and friends. But, you know, potentially the quality of CPR being provided by loved ones was potentially not as effective as somebody out on the street who's strong and willing to step in to a resuscitation effort. So, yeah, and then we looked deeper and we conducted a logistic regression model. And so we threw all of those factors that we know that influence cardiac arrest survival first of all, let me just go back a step. So when we looked at survival, we found a 50% decrease in survival rate, in survival to discharge. But then when we threw all those factors into a logistic regression model to sort of work out what it was that was, whether the survival decrease had continued, despite adjusting for those known factors such as bystander CPR and witnessed events and things like that, we still found that 50% reduction in survival. So the 50% reduction is due to other factors that, you know, potentially in hospital factors as well. There's potentially suggestion of early prognostication when patients get to hospital. Yeah, so those sorts of things. So very interesting findings.
Wow, that is interesting. It's very surprising to hear that. Some you can understand. I mean, a delay in defibrillation should result in a fall in survival, but still, so many moving pieces are changing all at the same time. So tell me, and feel free either Karen or Jocasta to jump in with an answer. Have you taken any corrective actions? Have you tried in any way to mitigate this finding, which is certainly worrisome?
So we have done a few things. So we've opened up our. So we stopped our lay public first responder program, which we do through the app, which is Good Sam. Because of the perceived risk of potentially infecting the public, we shut that down. So that is opening up in regional areas today. There was also some sort of education back to the paramedics, but I think the real corrective actions will come in the next analysis, as a result of the next analysis that we're about to do, because our survival has continued to decline. And so the next analysis that we're very interested in looking at is using our CPR pad data and looking at the quality of CPR. Because one of the clinical practice guideline changes that was made to potentially reduce the possibility of paramedics getting infected was to bring intubation in earlier in the arrest. And anecdotally, we're hearing that is resulting in hands-off chest time and poorer quality resuscitation. So we plan to really have a deep dive into our data to see if, in fact, that may be influencing it. I think we've also got to do quite a bit of education with the hospitals, because again, anecdotally, there was reports that there was reluctance to take patients outside of the emergency department and reluctance to take them up to the cath lab. So I think there's a big challenge for us to educate around the incidence rates of COVID infection in our cardiac arrest patients. In the first time period that we looked at, there was only one patient that had COVID, and they were a paramedic witness arrest, so actually didn't form part of our study. And we know now, Joe, how many arrests have we gone to that are COVID positive in the whole pandemic period?
So I think we're about 16. About 16. Yeah.
Yeah. So the incidence is, and there'd be a significant number of those that we wouldn't even commence resuscitation on anyway. So the likelihood of a cardiac arrest patient being COVID positive is so slim that I think that's really where we need to target our education.
Wow, very, very interesting. Several lessons really stand out. One, that the fact that you were measuring your performance on an ongoing basis so carefully keyed you into this problem, this concern, this dilemma. What's going on? And immediately suggested some potential changes that you could make in protocols, and again, keep measuring to see whether you've improved the situation. I really got to take my hat off. I'm not wearing one, but I'll take it off to you for the quality of your program to scrutinize everything you do, detect some problem going on, probably a multi-cause problem, but still a problem, and then taking corrective action to deal with it. Well, any last words, Karen? Any final advice to your other EMS cardiac arrest programs throughout the world? What advice would you have?
Yeah, I guess it's along the lines of what you said, Mickey. I think it demonstrates the value of an up-to-date clinical quality registry to be able to examine pretty contemporary data and look at the impacts of what's going on. And yeah, like I said, our excess deaths are not due to COVID. They're due to their strategies that were put in place to minimise the infection rate of COVID. And so I think, you know, looking at the unintended consequences of a lot of these actions is really important. And this, you know, we just don't know how long this pandemic will go on for. So I think it's really important that we're constantly evaluating and assessing.
Yes, I agree with what you just said, Karen. That's exactly right. Jocasta, any final words you'd like to share?
Yeah, I think that I agree with Karen that we have to keep measuring this. There are some really important learnings out of this work and our continued evaluation of the data. So yeah, I think it's a very important topic.
Well, again, it's a nice job you've done to identify a change, a dramatic change, and now to get really granular and start looking at what are the reasons and the corrective actions. So be interesting. We'll maybe have you back in a few months to see whether these changes have made any difference. So Karen and Jocasta, thank you very much for sharing your situation in Victoria. And we wish you success, hope things get better, and thank you so very much for being part of this podcast. So long.
Thanks, Mickey. Our pleasure.
Bye, everyone.
Thanks so much. Bye.